She picked up her coffee mug the way she had 10,000 times before. Same kitchen, same morning light coming through the window, same mug her daughter had given her years ago. But she stood there. Just stood there. Not because she forgot what she was doing, but because for a moment, just a moment, she didn't recognize the hands holding it. I've seen this before, and I've learned that what happens next matters more than most people realize. My name is Dr. William Sterling. I've been practicing medicine for over 2 decades, and for most of that time, my work has focused on one thing: understanding what happens to the body and the mind as we age. Not just the numbers on a lab report, the lived experience. What it feels like when something changes inside you and nobody around you can see it. In the next 18 minutes, I'm going to show you something that most doctors never explain. Not because they don't care, but because they were trained inside a system that got one critical thing wrong. And that mistake has been quietly affecting millions of women for over 20 years. There is a window, a specific period in a woman's life when a single decision can change the entire trajectory of what comes next. Her memory, her mood, her sense of who she is. Most women never know this window exists, and almost nobody tells them it can close. But before I tell you what that window is, I need you to understand what's actually being lost, because it's not what most doctors are looking for. Let me ask you something, and I want you to really sit with this. Have you ever been in the middle of a sentence you've said 100 times, and the word just wasn't there? Not a complicated word, a simple one. Gone. Have you ever walked into a room you love, your garden, your kitchen, a place that used to feel like yours, and felt strangely distant from it? Like you were visiting instead of living there. Have you ever looked at a photograph of yourself from a few years ago and thought, not about how you looked, but about how you felt, and realized you can't quite remember feeling that way anymore? If any of that sounds familiar, I want you to know something important. You are not depressed. You are not losing your mind. And you are not just getting older. What you are experiencing has a name, it has a cause, and it has been misdiagnosed, or simply missed, more times than I can count. The answer starts with a woman I'll call Carol. And what happened in my office the day she came in changed the way I practice medicine. Carol was 59 years old when she first sat across from me. Retired teacher, sharp, organized. The kind of woman who arrived early to every appointment and had her questions written down in a small notebook. By any external measure, she was doing fine. But she wasn't fine, and she knew it. She told me she had seen 3 doctors in the previous 2 years. One had suggested antidepressants. Another had told her that fatigue was normal at her age. A third had run a basic panel, found nothing alarming, and told her to focus on sleep hygiene. She had tried all of it, and she still felt like a stranger in her own life. What she described to me wasn't sadness. It wasn't the kind of darkness that depression brings. It was something more disorienting than that. She said, and I remember this clearly, she said she felt like she was watching herself from slightly too far away. Like the volume on everything she used to care about had been turned down. Her garden, her grandchildren, the books she used to devour, still there, still present, but somehow behind glass. She had stopped telling her husband how she felt because she couldn't find the words that didn't sound dramatic. She had stopped mentioning it to her daughter because she didn't want to worry her. She had started to wonder, quietly, privately, in the way women of her generation tend to carry things, whether this was simply who she was now. I looked at her intake form. I looked at what had been tested and what hadn't. And I saw something that 3 other physicians had passed over entirely. Not because they were careless, but because they were looking for the wrong thing. What Carol described wasn't a mood disorder. It wasn't aging. It was something being quietly dismantled, and there was a biological reason for every single piece of it. To understand what was happening to Carol and what may be happening to you, I want you to think about an old house, not a neglected one, a well-loved one, the kind that's been maintained carefully for decades. Good bones, solid foundation, a place that feels like itself. Now imagine that the person responsible for the upkeep, the one who notices when a door starts to stick, when the insulation needs checking, when the pipes need attention, quietly stops coming. No announcement, no dramatic event, just absent. At first you don't notice much. A window that doesn't latch quite right, a draft you can't locate. Small things, easy to explain away. But over time, the house begins to feel different. Not broken, not ruined, just not quite like itself anymore. That is what estrogen does in the female brain. And that is what happens when it leaves. Estrogen isn't just a reproductive hormone. That's the part most people know. But what most people, including many physicians, don't fully appreciate is that estrogen is deeply involved in how the brain maintains itself. It supports the circuits involved in memory formation and retrieval. It influences the systems that regulate mood and emotional response. It plays a role in how the brain processes and responds to stress. And critically, it is involved in the sense of cognitive continuity, the feeling of being the same person day after day that most of us take completely for granted. When estrogen declines, which in menopause it does, significantly and often rapidly, all of those systems feel the shift. Not all at once, not dramatically, but steadily. Like the house whose maintenance has quietly stopped. This is why Carol's 3 previous doctors missed it. They were looking at the stuck door, the drafty window. They weren't asking why the maintenance had stopped, or whether anything could be done to restart it. So if estrogen is doing all of this, why are so many women still told to simply wait it out? Why is give it time still the most common advice? The answer is complicated, and honestly, it made me angry when I finally understood it. In 2002, a major study made headlines across the country. Every major newspaper carried the story. Television news ran it for weeks. The message was simple, alarming, and, as it turned out, deeply incomplete. Hormone therapy causes cancer. Hormone therapy causes heart attacks. Stop. Avoid. Fear. Millions of women threw away their prescriptions overnight. Millions more never started. And an entire generation of physicians, trained inside that fear, learned to say 2 words whenever a patient like Carol walked in. Wait it out. Here is what the headlines never told you. The women in that study had an average age of 63. Many were in their late 60s and 70s. They were, on average, more than a decade past menopause. And the hormones they were given were formulations that are rarely the first choice today. That study was not testing what happens when you support a 52-year-old woman whose hormones just declined. It was measuring something else entirely. But the fear it created didn't make that distinction. Fear rarely does. When researchers went back and looked specifically at younger women, those who started hormone therapy within 10 years of menopause, the picture changed completely. The elevated risks that had frightened an entire generation were not there. In some analyses, the opposite was found. This is the window I mentioned at the beginning, not a metaphor, a clinical reality. There is a period, roughly the first 10 years after menopause and ideally before age 60, when the evidence most strongly supports intervention. When the brain and the cardiovascular system are most likely to respond protectively. When the maintenance, as I described it earlier, can most effectively be restarted. After that window narrows, the calculus changes. Not impossible, but different. Which is exactly what made Carol's situation so important. And exactly what I saw in her file that 3 other doctors had passed over. She was 59. The window was still open. But even when women are treated, many still don't feel like themselves. And there is a reason for that too. I want to be specific now, because the symptoms of hormonal decline in the brain don't always look the way people expect. They don't announce themselves. They hide inside ordinary moments. And over time, women stop mentioning them because they've learned that nobody takes them seriously. So let me take them seriously. The first place it hides is in language. You're telling a story you know well, and a word disappears. Not a technical word, not a name you rarely use, a plain, ordinary word. And in the half second it takes to realize it's gone, something else happens. A flicker of something that feels like shame. You cover it. You move on. But you notice. And you start to dread the next time. I've seen patients who stopped telling stories altogether because of this. Not because they had nothing to say, but because the fear of losing the word had become louder than the story itself. The second place it hides is in motivation. The things that used to pull you out of bed in the morning. A project, a garden, a plan, a person are still there, but the pull is weaker. You do them. You show up, but you're waiting to feel the way you used to feel about them, and that feeling doesn't come. Many women tell me they assumed they had simply grown out of the things they loved. They hadn't. Their brain's reward circuitry was running on lower fuel. The third place is in emotional proportion. A small frustration lands like a large one. A minor disappointment feels crushing for 20 minutes and then evaporates completely. You find yourself apologizing for reactions that surprised even you. And then comes the secondary layer. The confusion about why you reacted that way, followed by a quiet worry that something is wrong with your character. Nothing is wrong with your character. The system that helps regulate emotional response is under-resourced. That is a clinical statement, not a consolation. The fourth place is harder to describe. It's the feeling of watching your own life from a slight distance. Being present, at dinner, at a family gathering, in a conversation you're genuinely part of. But feeling like the glass between you and the moment is just a little too thick. You're there, but you're not quite in it. I've had patients describe this as the loneliest symptom of all, not because they were alone, but because they were surrounded by people who couldn't see it. And the fifth, the one women mention last, almost always in a quieter voice, is the fear that this is permanent, that the version of themselves that existed before, curious, present, warm, sharp, is simply gone. I want to tell you about another patient, because her story is different from Carol's, and the difference matters. Ruth was 67 when she came to see me. She had been told for years that what she was experiencing was normal. Age-related cognitive slowing, stress, the natural rhythm of life after 60. She was a practical woman. She had accepted it. What struck me, sitting across from her, was not what she said. It was how she said it. Calmly, without complaint. The way someone speaks about something they've made peace with. Not because they wanted to, but because they ran out of other options. She had been 17 years past menopause. 17 years. The window I described, the one defined by timing and biology, had narrowed considerably. We could still do meaningful work together. There were still paths forward, but they were different paths than Carol's. More careful, more limited in scope. The biology had moved on in ways that changed what was possible. I think about Ruth often. Not because her outcome was without hope, it wasn't, but because of something she said near the end of our first appointment. She said she wished someone had told her, 15 years earlier, that there was a decision to be made. Not that she would have necessarily made it differently, but that she would have liked to have known. She deserved to know. Carol and Ruth. Same condition, very different timing. And that difference is exactly why I need you to hear what comes next. There is something I say to patients when we reach this point in the conversation. I've said it hundreds of times, and every time I watch something shift in the room. A tension that's been held for years, sometimes quietly, sometimes not, begins to release. I tell them this: you didn't change. Your hormones did. And there is a difference, because one of those things can be addressed. Read that again if you need to. Let it land. Because for so many women, the cruelest part of this experience isn't the symptoms themselves. It's the story they've been quietly telling themselves about what the symptoms mean, that they've become less, that the best of them is behind them, that the woman in that photograph, present, engaged, fully herself, is someone they used to be. She isn't gone. She's waiting on the other side of a biological shift that has a name, a mechanism, and in many cases, a solution. Remember the woman in the cold open, standing in her kitchen, holding a mug she'd held 10,000 times, not recognizing her own hands. That moment wasn't the beginning of an ending. It was a signal. And signals, when understood correctly, point toward something. So let me show you exactly what addressing it looks like. Not in theory, in practice. Starting this week. What I'm about to share is not a prescription. It's a framework, the same one I walk through with patients who are ready to stop waiting and start making informed decisions. Each step matters. Each one builds on the last. Step 1. Start documenting, but not what you think. Don't track hot flashes or sleep hours. Track disconnection moments. The times you felt behind glass. The word that disappeared. The afternoon you couldn't find the pull towards something you love. Write it down. Date it. One line is enough. I've seen patients who dismiss these moments for years because they had no language for them. Writing them down does two things. It tells your doctor something specific and useful, and it tells you that what you're experiencing is real, it's consistent, and it deserves attention. When patients skip this step, they walk into appointments and say, "I just don't feel like myself," and leave with nothing actionable. When they bring a record, the conversation changes entirely. Step 2. Ask for the right panel. A standard blood workup will often miss what matters here. You want estradiol, the primary form of estrogen, tested, not just noted as within range. Ranges vary. Context matters. You also want FSH tested, which helps confirm menopausal status and timing. Ask specifically. Write it down before your appointment. I've seen patients told their hormones were fine when the numbers in context told a very different story. You are entitled to understand your own results. Step 3. Find a physician who is current on menopause care. This matters more than it should. The landscape of hormonal medicine has changed significantly in the last 15 years. Not every physician has kept pace. You are looking for someone who understands the timing hypothesis, who is familiar with transdermal delivery options, and who will discuss your individual risk profile, not apply a blanket policy. If your doctor's response to menopause symptoms is still, "That's normal for your age," it may be time for a second opinion. I've seen patients stay with physicians who weren't serving them well because they didn't want to seem difficult. Advocating for your own care is not difficult. It's necessary. Step 4. If hormone therapy is appropriate for you, ask about transdermal delivery. This is the formulation delivered through a patch, a gel, or a spray, absorbed through the skin rather than processed through the liver. The distinction matters clinically. Oral estrogen passes through the liver first, which can affect clotting factors. Transdermal delivery bypasses that process entirely, and for many women, meaningfully changes the risk profile. Additionally, if you still have your uterus, ask about micronized progesterone specifically. The evidence suggests it carries a more favorable profile than some older synthetic alternatives. These are not small details. I've seen the difference they make, both in outcomes and in how women feel on treatment. Step 5. Support the treatment with 3 non-negotiables: sleep, light, and movement. Not as lifestyle advice, but as biological amplifiers. Consistent sleep timing helps regulate the hormonal signaling that treatment is trying to restore. Morning light exposure within an hour of waking influences cortisol and serotonin in ways that compound the effect of estrogen support. And resistance-based movement, not just walking, but anything that asks your muscles to work against load, supports bone density and cognitive function in ways that are well documented. I've seen patients on identical protocols respond very differently based on these 3 factors alone. They are not optional additions. They are part of the protocol. Step 6. Know what to look for and when. The signs that something is shifting often appear before the obvious symptom relief. Sleep quality tends to improve first, then a subtle but unmistakable change in morning energy. Then, and this is the one patients remember, a moment when they're in the middle of something ordinary and they realize they're actually in it. Not watching from behind glass. Present. That moment is not a small thing. I've had patients call my office just to report it. Carol did. She was standing in her garden. She said it felt like coming home. Before we go any further, I need to be honest with you about something, because this conversation isn't complete without it. I want to be straightforward with you now, because everything I've shared today comes with an important qualifier, and I'd be doing you a disservice if I didn't say it clearly. Hormone therapy is not appropriate for every woman. If you have a personal history of certain hormone-sensitive cancers, or a history of blood clots or stroke, or specific cardiovascular conditions, this conversation looks different for you. Not closed, but different. Your physician needs to know your full history before any decision is made. And please, do not stop or start any medication based on what you've heard today. Talk to your doctor first. Always. There are also situations that require immediate attention, not a scheduled appointment, but a call or a visit today. Sudden confusion that came on quickly. Memory gaps that are new and significant. Mood changes that feel severe or unsafe. If any of that is present, for you or someone you love, please don't wait. Call your doctor, or call 911 if the situation warrants it. What I've described today is a framework for informed, proactive care. It is not a substitute for a physician who knows you. The goal is a conversation, an informed one, with the right questions, with a doctor who is current. That conversation can change things. I've seen it change things. And that is exactly what I want you to understand before we close. Carol came back to see me about 4 months after we started working together. She didn't bring her notebook that day. I noticed that immediately. The woman who had always arrived with questions written down in careful handwriting walked in without it. I asked her about it. She smiled, a different kind of smile than the one I'd seen at our first appointment, and said she hadn't needed it. The questions had stopped feeling urgent, not because she'd given up, because she'd started feeling like herself again. She was back in her garden, not because she'd scheduled it, because she wanted to be there. She was telling stories again, long ones, with all the words in place. She said her husband had looked at her one evening across the dinner table and said quietly, the way long marriages sometimes speak, that he'd missed her. She had been there the whole time, and now she was back. I've thought about what it means to practice medicine long enough to see both sides of this. The patients who came in time, and the ones who didn't. The ones who were told to wait and waited too long. Menopause. And the ones who asked the right questions at the right moment and changed what their next decade looked like. The difference between those two groups is rarely dramatic. It's usually one conversation, one appointment, one decision to stop accepting that's normal for your age as a complete answer. You didn't change. Your hormones did. And there is a difference, because one of those things can be addressed. The window may still be open. And knowing that, truly understanding what that means, is where everything starts. If something in this video made you stop and think, share it with someone who needs to hear it. A friend, a sister, a daughter who is watching her mother and wondering. This information changes conversations, and conversations change outcomes. And I want to hear from you. Tell me in the comments, what was the moment, the specific moment, when you first felt like you weren't quite yourself anymore? When did you first notice? You might be surprised how many women are waiting to read exactly what you're about to write.